This Medicine's ECG review will focus on case number 196 from ECG Wave-Maven. Copyright information is provided here. We have a 54-year-old man with rest chest pain. Which statement about this ECG is correct? We have nonspecific T-wave abnormalities, slight inversions in 1 AVL and V4 to V6. There's nonspecific STT changes with slight lateral T-wave inversions which are present. The patient was ruled in for a myocardial infarction. Cardiac catheterization revealed a single vessel coronary disease with a 95% occlusion of the dominant right coronary artery. The ECG also shows non-diagnostic Q waves in 3 and in AVF, and a relatively tall R wave in V2, but not in V1, raising the possibility of a prior inferior posterior MI. However, these findings are not diagnostic. A wide array of factors may cause nonspecific STT changes. Digitalis, however, does not cause the type of slight T-wave inversion seen here. Rather, it usually produces shortening of ventricular repolarization with scooping of the STT complex. Prinzmetal's angina is defined by the appearance of ST elevations with non-infarctional ischemia. Left posterior fascicular block leads to marked right axis deviation in the absence of other causes. The QRS axis is normal here on this EKG. Care must be taken not to overinterpret nonspecific STT changes, particularly in patients with a low prior probability of heart disease. However, as illustrated by this case, subtle repolarization changes, especially slight ST depressions or T-wave inversions, can be important markers of acute or chronic coronary syndromes. Of course, even a normal ECG does not exclude acute ischemia. This is the patient's cardiac catheterization. This is the left anterior oblique view of the right coronary artery, demonstrating critical stenosis in the mid portion of the artery.